And good evening, everybody. Welcome to the Prostate Forum. For those of you not familiar with us, we are based in Southern California here in the United States. We are a 27-year-old plus prostate cancer support and information group. And we are going all over the world, literally, for important information about the diagnosis and treatment of prostate cancer. We have a special treat tonight. We have Dr. Elie Dolgin, who is with us, who is a science journalist based in Somerville, Massachusetts. He is a former news editor at Stat, Nature, Medicine, and The Scientist. His work appears regularly in Science Magazine, Nature Magazine, and the New York Times, as well as other publications. He has written frequently about radiopharmaceuticals, and is most recently a featured story for Knowable magazine that was republished in Discover magazine and ARS Technica. A translation when we talk about tonight's radiopharmaceuticals strike cancer with precision. What we're talking here is also called theranostics, something we get into in our support groups at the Prostate Forum.
First, a quick word about the Prostate Forum. The Prostate Forum has been active for more than 30 years, offering information, education, and hope to anyone affected by prostate cancer. We host online support groups twice a month on the second and fourth Tuesday. These sessions provide a safe place to share experiences and support each other. To stay informed about upcoming meetings, simply register on our website, prostateforum.org. On the fourth Tuesday of most months, we offer special presentations just like this one, featuring leading experts in prostate cancer. These sessions provide valuable insights and the latest information on treatments and research, helping you stay informed and empowered. You can find almost 100 previous presentations on the website at prostateforum.org/presentations. And if you subscribe to this YouTube channel, you'll be notified when new presentations are released. Finally, remember, you can make a difference. The Prostate Forum is an all-volunteer organization, so we always can use your help to help others. Consider volunteering your time or making a donation to support our work. Your time and expertise can be used to organize support for outreach, for content creation, and for website maintenance. And your donations help us continue to provide these vital resources and support services. Visit our website to learn more about how you can get involved, make a donation, and have a positive impact.
Dr. Elie Dolgin.
All right, thank you. Good, you can see my my slides. Yeah, so thanks, Neil, for the introduction. As you mentioned, science journalist. I've been doing this now for about 15 years, and one of the fun and interesting things is you get to learn about new and exciting areas of biomedical research, but also revisit topics as new developments arise. So I think I first started writing about some of these radiopharmaceuticals, radiotherapeutics, radioligand therapy, theranostics. There's a lot of different terms that all mean essentially the same thing. I'm probably going to use the term radiopharmaceuticals or radiotherapeutics a lot, but it's just jargon essentially. But so writing about it for the last couple of years, and then it's just kind of exploded, and we'll get into some of the reasons why in this talk. If anyone's interested to learn more, I'll point you to that article that Neil was talking about in Knowable magazine. It's an online publication through the annual reviews journals, but it's accessible to a general audience. And as you mentioned, the story was republished in Discover, Ars Technica, and actually most recently in El País, their English edition. So it's making the rounds, which is great. That story kind of is more broadly, I think the title of it is Radioactive Drugs Strike Cancer with Precision. I just tweaked the title ever so slightly to insert the word prostate there, but really Pluvicto, which is the drug the name brand of the drug I'm going to be talking about a lot tonight, which is for PSMA positive prostate cancer. That's like the shining example in this emerging area of drug development. So it really is a story where the prostate cancer angle is very prominent. If anyone wants to get in touch or has any further questions about me, my website is just myname.com. All right. Let's, when you give a talk, you have to have disclosures. So a couple disclosures up top. Firstly, I just want to say I am not a doctor. I did do a PhD, a British PhD, so it was a little shorter, but it was in basic research. And so I've done my reporting and research in this area of drug development, and I write about biomedical research a lot. But I just want to say, like, anything that I say, please do not construe as medical advice. If you are intrigued about any of the drugs or trials that I might mention tonight, as they say, ask your doctor. Don't take my word for it. The other thing I will say is, so it's 8 o'clock here. I live in Boston, or the Boston area. These are my two kids. This is not what they look like right now, which I can guarantee you, because my wife got caught up late at work, and so I had to quickly stick a iPad in front of them. Don't tell their grandfathers if they're on this Zoom. But hopefully they don't come running in or scream in an emergency. But I'll just note that I do have these two kids who need to be going to bed. But I think it'll be fine. And just the last thing I'll say, as a middle-aged man with a mustache, we need more mustaches. Like, every month should be Movember. I don't get it. Why only 1 month a year? I know that's neither here nor there, but that's just a little political plug there for mustaches. Okay, so let's talk about radiopharmaceuticals, and the drug really that changed the landscape, and that we're really here to talk about first and foremost is Pluvicto. That's the brand name. But under where it says Pluvicto there, you'll see the generic name. And I just want to dissect that, because I think it'll help us understand what it is we're talking about. So the first part of the name is lutetium, and then Lu-177. So lutetium is an element in the periodic table, and it can come in different isoforms or isotopes. And so depending on the ratio of neutrons and protons. And so lutetium-177 is a unstable or radioactive form of lutetium. And so that's the radiation part of the radiopharmaceutical that's in here. And then it is attached to a drug component, and that's this I'm not even going to try to pronounce it. That's the PSMA molecule, essentially, if people have heard of PSMA. So that's prostate-specific membrane antigen, not to be confused with PSA, of course. But that's a receptor protein expressed on the surface of prostate cancer cells. And so the drug is essentially two things in one. It's a drug that will target your cancer cells with the vipivotide, the PSMA part, and then the radioactive warhead. So here I'm just illustrating that radioactive bit, drug bit, and here's just another way to visualize the same thing. This is what we're talking about here with radiopharmaceuticals. A radioactive particle attached via a linker, is what they call it in chemistry, to some kind of cancer targeting drug. And that cancer targeting drug can be a small molecule. In the case of Pluvicto, it's a peptide, so like a small bit of protein. It can also be an antibody. It just has to latch on to that target protein on the surface of the cancer cell, engage with it, and then it gets internalized, releasing the radiation hyperlocally right at the site of the cancer. And so this is just another way of conceptually thinking about what we're talking here. On the left, the first picture is kind of conventional beam radiation. So you have to know where the cancer is, and you position the patient or the body just so to the right organ, prostate, and you try to zap it essentially with high dose radiation and avoid healthy tissues as much as you can. What's different here is we don't even need to know where your cancer is for this drug to work. You don't have to find the little micro metastases to zap. If you if you know that the cancer expresses the protein that the drug is targeting, you just give it inside the body, the drug gets to the cancerous tissue and releases its radioactive payload right at the site of the tumor. So it's fundamentally a different way of administering radiation, delivering it inside the body essentially with these kind of heat-seeking missiles, as opposed to from outside through different kind of technologies to point at the right way at the cancer. So with that in mind, I just want to give a little bit of a history, a backstory here. So in the black and white, we have early days of radiation therapy. So this is a woman, I don't even know what kind of cancer she had on her face, but she's, you know, getting x-rays applied straight to her face to try to deal with some facial mass. And it looks horrible. Obviously, not all radiation therapy is like that now. We've improved a lot, for sure, both in the kinds of radiation they give and the ways that they give it, and the, you know, computer-guided approaches to ensure that we just strike the cancer. But this new approach, you know, here's a picture. This is actually, just do a little bit of California pandering here, but this is a picture from UCSD of a man named Jim Duvall from a couple of years ago getting Pluvicto. And he's just getting it infused into his arm like any other IV drug. You wouldn't know it was radioactive from that picture per se, except from maybe the plastic. I don't even think so. So anyways, so this is a kind of an unwieldy history here. And you can ignore the details. You could see the years and stuff, and I'll get to some of the bullet points. Not all of them are super important, but basically, this is the 100+ year history of how we went from crude radiation to Pluvicto. And I'll just break up that history into kind of 3 main eras, okay? There's like an early era, real rise of the radiopharmaceuticals, and the kind of the modern era. So if we look at the early history of this kind of idea of like a drug that has radiation and finds the cancer, okay? Actually, one of the very first uses of this was with an isotope of radium. And for people who think, oh, I've heard of radium, one of the reasons you might have heard of radium and radioactive radium is actually this drug, Xofigo. So 100 years after this first treatment with radium, actually we get this drug Xofigo, which is a slightly different form of radium, just the nature of the isotope. And for people who I probably don't need to tell this audience, but Xofigo is a drug approved for prostate cancer that has metastasized to the bone. And the way it fundamentally works is that this form of radium, which is kind of formulated into a salt for kind of special kinetic reasons to do with the tissue and the nature of bone and metastases in the bone, it kind of goes preferentially to those mets in the bone. And then once it's there, it kind of destroys them with the radiation. And so, but this I would consider not exactly targeted radiopharmaceuticals. This is in some ways a special, unique case, because I'm not saying you kind of get lucky with radium, but it's just like a quirk of radium, and it's a quirk of prostate cancer metastases in the bone that this strategy works. And there's probably one other cancer where this type of idea works as well, and perhaps much better known, and that's radioactive iodine. So this, because the thyroid gland naturally uses iodine, dietary iodine, that's why we have iodized salts and things like that. You need iodine for the thyroid gland to produce its hormones. So if you make that iodine radioactive, the thyroid gland doesn't, start to anthropomorphize, but it doesn't realize that it's radioactive. It takes up the iodine the way it would with any other iodine, and then you get this localized radiation. So here's just an illustration of that. But you swallow it. In that case, you swallow it. I think with Xofigo, it's intravenous, but you swallow it, it goes to the gut, and then it through the blood, and then it ends up back in the thyroid. And then once it builds up in the thyroid where it's the radiation, the radioactive isotopes are decaying, and that's what causes this kind of localized effect on the thyroid tumor. But that's kind of it for that kind of quirky nature of different radioactive elements that just happen to get taken up by different tissues. That is not, you know, the kind of targeted radiopharmaceutical I was showing you before with the radiation, the linker, and the cancer targeting drug. So we fast forward to kind of the 80s into the 90s and 2000s. This is really the heyday, the growth of this strategy of building those targeted agents with a radioactive warhead. Again, this is just kind of showing that again, what it looks like. And just to drive home the mechanism here, because I think it's really important, and I apologize if this is feeling redundant, but what you'll see here, so you've built the cancer targeting drug. It will bind to the receptors on the surface of the cancer cell. In the case of Pluvicto, that's PSMA. But it can bind in any number of ways with an antibody, a small molecule protein. The drug, that whole thing then gets internalized. The radiation is kind of happening all along because the radioactive isotope is unstable. So it's just constantly kind of decaying. But the amount of time that it spends outside of the cancer cell is minimal, because once it latches onto its target, it gets taken up inside the cell. It really starts releasing its radiation. That damages the DNA, leads to cancer death. So that's the basic idea. Here's another visual depiction, same idea. Goes into the bloodstream, taken intravenously. Once in the bloodstream, it finds its targets on cancer cells, releases the radiation, kills the cancer. I should note, just as an aside, before we get back to the history here, but the term theranostics is this combination of therapeutics and diagnostics, right? And so one of the things about this whole modality, and I've been talking about the pharmaceutical, the therapeutic side primarily, but basically you take the same construct of the targeted agent and you just change up the radiation, and you can have an imaging agent or you can have a cancer-killing drug. And so some radioactive particles, as they decay, they release fairly benign types of radiation, what are known as gamma rays. And these are radioactive enough you can image it via PET or other imaging modalities, but it's not going to kill the cancer. And then you put on it, you can have different types of radiation, and then that actually will kill cancer cells by shredding the DNA. And there's different kinds of, they're called alpha emitters and beta emitters, depending on the kind of particles, and we'll get into that in a little bit. So basically, you've got the imaging modality with sort of a benign radioligand product. And actually, you can't really get a radiopharmaceutical unless you do the imaging first, hence the theranostic part. You have to do the diagnostic part and the therapeutics, because for Pluvicto, say, you need to know that you have PSMA on your cancer cells, otherwise it's a useless drug. So you would go through one of these processes with a benign agent just to make sure your cancer is expressing PSMA, and then you come in with the Pluvicto, which can be almost exactly the same. You just have a kind of a heavier hitting radioactive warhead. Now I'm going to try to figure out how to see chats. Okay, yes. Nothing is medical advice. Okay, thank you. So back to our middle age, or sort of middle history. And so there was all this work to kind of develop those constructs. A lot of the work was happening in Europe for regulatory reasons. They can kind of do these compassionate use type trials, which is a little easier to run these early studies. A lot of the early work was actually not around prostate cancer, because people hadn't yet found PSMA or the right target. It was mostly around neuroendocrine tumors, which are fairly rare tumors that can arise in these specialized tissues of the body. And they just happen to express things called somatostatin receptors. And so people discovered that and could build these radioligand therapies that were like Pluvicto, but instead of PSMA, you're targeting the somatostatin receptor. And so a lot of that work is happening, and they're developing these agents. But actually, arguably some of the first kind of real therapeutically or clinically successful radiopharmaceuticals were approved actually in the US in the early 2000s. You've probably never heard of them, but they were called Bexar and Zevalin. And they What you may have heard of is Rituxan or rituximab, which is a lymphoma drug. It targets a receptor found on B cells called CD20. And so these are basically versions of rituximab with radioactive payload. So instead of just targeting the CD20 molecule found on lymphoma cells, it also carried this radiation and delivered the radiation. The drugs seemingly worked really well. It was sort of for commercial reasons. The problem is rituximab also actually works really well and had kind of an early mover advantage, and people didn't really know how to use these radioactive agents, and also the manufacturing of these molecules and the distribution is a lot harder because they're radioactive. So it just, there's a lot of logistics around it. So basically these two drugs kind of died as soon as they were approved and never really took off. But it's worth highlighting that this idea has been around for over 20 years at this point. But if we jump ahead to kind of the modern history here, where things really start to take off is when a lot of that early work on the neuroendocrine tumor drugs, the ones that target the somatostatin receptors, that eventually works its way up through clinical development, shows success in phase 3 trials. And that's when Novartis basically comes calling. And so Novartis deserves a lot of credit. I mean, they're earning a lot of money too for their seeing the potential here, but they were kind of an early mover among the big pharma players here. They had actually been dabbling in some of these trials. You'll see here in 1997, you see, I don't know if people can read that, but Novartis was doing studies in the neuroendocrine tumors. Those early efforts didn't pan out. They pulled out, but they come back into the field in 2017 when they spend around $4 billion to buy the maker of what would eventually become Lutathera. So that's the drug that looks a lot like Pluvicto, but instead of targeting PSMA, it targets these somatostatin receptors for neuroendocrine tumors. And about a year later, so they buy up this company for $3.9 billion, right as it's about to be approved, and a lot of that money is actually for the infrastructure, because it's not easy to make these drugs and to distribute them, as I was saying. So a lot of what they're buying is the know-how, the manufacturing know-how, and the plants and all that kind of stuff to distribute these drugs. But they kind of double down on their investment in this field when they, a year later, spend $2.1 billion to buy Endocyte, which is the original developer of Pluvicto. The reason why they spend less for that company is because it hadn't gone through phase 3 trials yet. So they were taking a risk, because any drug can look good in phase 1 or 2 and then ultimately flop. But they were believing in it, and so they invested, they bought Endocyte, they took Pluvicto into that phase 3 trial, and here's quickly just kind of top line what they saw on the efficacy front for people who haven't seen this before. Basically, you have this randomized clinical trial. Patients can either get standard of care, kind of whatever the physician feels is appropriate. I should say this is all metastatic castration-resistant prostate cancer, so pre-treated with an androgen receptor pathway inhibitor, and in this case also people who received chemotherapy with a taxane drug. And so this is late stage. Things are looking pretty bad, as I don't have to tell this audience, I'm sure. And so patients were randomized to get either standard of care or standard of care plus Pluvicto. And the difference here was, massive and statistically significant. And these are just averages, of course. So some people do a lot worse, some people did a lot better. So you had an extra 5 months or so of progression-free survival. So that means time without the cancer progressing according to imaging scans. And then ultimately the median time to death was 4 months longer as well for this patient population. So quite a clinically significant improvement, and that leads to the approval of Pluvicto. Sorry to jump around on the history here. I pull this up just to again point out that Pluvicto doesn't come out of nowhere. Obviously, there's a history on the development of PSMA as well, going back to the late 20th century, and also emphasizing the sort of theranostic concept of this whole area of drug development, it's worth highlighting that, of course, before Pluvicto came around, you needed ways to identify patients who had PSMA expression on their prostate cancers. So beginning around 2020 and 2021, we get these imaging agents. So here's a couple of the ones that use gallium. So this is one of these more benign radioactive molecules that just produces the gamma rays. So this allows you to image whether patients have PSMA expression. And if they have PSMA expression in their body on a PET scan, it's on the cancer typically. And then you have a couple others that use a different molecule, fluorine. And then that ultimately paves the way to the approval of Pluvicto. And so obviously Pluvicto has, been rapidly taken up. I think it, not to dwell on sort of the business side of the industry, but it's a marker of uptake. I think the drug posted sales of $1 billion or something in its first year available. So it's being used, and I'm sure having, helping to extend the lives of countless men who are at this kind of late stage, few other options point in their odyssey with prostate cancer. But what it also does, because this is the kind of hive mind of the drug industry, as Novartis starts racking up profits, it makes everyone go, wait a second, this is like a real thing here, and we want a slice of the action. So in the past year alone, you've had a number of other drug makers all basically doing what Novartis did before, buying up these specialty radiopharmaceutical companies as they try to, a lot of the action is around kind of a better Pluvicto, and we'll get into some of the reason or some of the ways that Pluvicto can be improved upon, at least the technical aspects of that, but then also applying this same fundamental strategy of the radioactive warhead, the drug, the cancer targeting drug, to any number of other protein targets, any number of other cancer types. So as I intimated, so I think $10 billion in merger and acquisitions have happened over the past year or so. And now, in addition to Novartis, you've got Eli Lilly, you've got BMS, AstraZeneca, so kind of a who's who of big pharma oncology players. Right, just coming back to this picture, if you couldn't tell, it's from my Knowable magazine article. But we'll just focus on that key construct again. So the way that they're trying to improve upon Pluvicto essentially is tinkering with one of the three pieces that makes up these radiopharmaceuticals. So you've got in the middle, you've got the linker. And I'd argue that's the kind of the least important piece. I mean, the nature of the link, and I apologize if there are any sort of important chemists or bioengineers in the audience who are going to go, no, the linker is so important. I mean, each piece is important, and it's going to affect the kinetics of the drug and how it releases the radiation, things like that. But I think we can set that aside because it's really technical and not fundamentally that unique, I don't think. Tell me if I'm wrong. But the real innovation, I think, is happening both around the cancer targeting drug. So this is looking at different targets. The key here is that you need a target that is expressed preferentially on cancer cells and not on healthy tissues, because this drug is going to latch onto any cell that expresses that target. So you have to find this balance of cancer-biased expression. And then you can target that, as I said, with different types of technologies, each one having slightly different pros and cons, and it'll affect the kinetics of the drug and things like that. But the most exciting thing, I think, is around the radioactive payload. As I mentioned, Pluvicto and also Lutathera, the other one for neuroendocrine tumors, they both use the same lutetium-177 as their payload. But there are a lot of radioactive molecules to choose from. These are just some that I think have all gone into clinical trials, if I'm not mistaken. They've at least been tested in animals, but I think most of them in people to one extent or another. So here's your lutetium-177 in the middle. And there's kind of two attributes about it that I'm highlighting here. One is, we'll just start with the half-life on the right. So it's 6.6 days. this becomes important actually almost more for distribution and manufacturing and logistics. So early on, there was a lot of work around this other drug here, yttrium-90 at the bottom, but you'll see it had a half-life of only around 3 days. So less than every 3 days, half of the radiation is dissipating from your vial. So if it takes you, I don't know, 5 days to get it from the factory to the patient's arm, you're basically at kind of 1/4 power, whereas with lutetium-177, you haven't lost as much of the radiation. So that becomes really important to have something that has like a manageable half-life, so you can get it from the factory into the patient as efficiently as possible. And there's a whole manufacturing logistics complexity to this. I won't bore this audience with that, but they have, all these companies have to think about, like, you have to overdose into the vial knowing that it's going to take a while to get to the patient, and to also make it at just the right time so that it can be sent out and FedEx quickly to the right hospital. And it's quite an ordeal. And actually, after Pluvicto was approved, there was a massive shortage of it for a little bit, because it kind of, I think the generous interpretation is that there was some growing pains effectively for Novartis, and they made a big deal of the fact that they opened some new almost billion-dollar factory in Indianapolis. And now they're like, no more shortages, and we're going to do this, and we're going to get it right. So, but I just will highlight that this isn't like making or distributing other drugs that can just sort of sit on the pharmacy shelf. This is, this is a radioactive little bomb that you have to figure out how to make and distribute quickly. But in some ways, the more interesting attribute here is the emitter type. And so you'll see most of the things here are either alphas or betas. And so key here is that lutetium-177 is a beta emitter. And where a lot of the interest and action now is on this top one, actinium-225, which is an alpha emitter. And what that means is, so here's some like cartoon basic physics here. But so you have your starting molecule, it's radioactive, so it's going to decay. And so different types of radioactive molecules will decay in different ways. And so as I mentioned, I'll just go at the bottom for a sec here. Something like gallium-68, when it decays, it just releases these gamma rays. And those are pretty benign, allowing you to do imaging. But these other molecules, an alpha emitter or a beta emitter, when they decay in different ways. And an alpha emitter releases what's called an alpha particle. It's like a helium particle. You see it has 2 protons and 2 neutrons, which is a molecule of helium. But imagine like a molecule of helium going off inside your cell and shredding your DNA. And then the other type, the beta particles, are electrons. They're just tiny little charged electrons. And so you have these 2 different kinds of emissions, and they have different properties. Oops. So a beta particle, that small little electron one, it's pretty low energy. This is LET, it's a measure of energy. So low, I have colored here in blue. So it's a lower energy. It's still enough to nick DNA, but it doesn't like shred DNA essentially. So it damages DNA, but it doesn't destroy. So this is, I don't know, I can make some sort of horrible war analogy, but I won't, to spare us from that. But the other thing that a beta particle does, so it's a lower energy, and also it will travel further as it's decaying and before it loses all its energy. And whereas an alpha particle is like this tiny little bomb going off that just like blasts the DNA, destroying the cell, but also doesn't travel very far. And why that's important is that a beta particle will not only tear through the DNA of the cell it's in and adjacent cells, all of which might be cancerous, but it might get into the neighboring healthy tissue, the neighboring stroma, and cause kind of collateral damage, or the kind of side effects that traditional radiation has. As you shine a radiation beam, you invariably hit some healthy tissues as well. Whereas an alpha particle, in principle, it's only really damaging the target cell and maybe 1 or 2 neighboring cells, but it's really hyper-localized. And so a lot of the action and interest now is around moving from the beta particle, beta emitters, like that is in Pluvicto, to one of these alpha particles, with the idea being that it will be better at killing the cancer, and hopefully have fewer side effects. And so here is kind of the pipeline as of, I think I stole this from someone who had amassed this like 6 months ago or something, but pretty recent pipeline of all the different radiotherapeutics that are in development for prostate cancer. And so you have phase 1, phase 2, phase 3. That's just first in human. It's called phase 1. Phase 2 is where you look for signs of efficacy. Phase 3 is the sort of pivotal trials you use to get FDA approval. And in here, I'll just try to talk you through some of the more interesting elements of this chart. You don't have to read all the data points, but each of the shapes means something. It means the way that you target the cancer. So a triangle is an antibody, a circle is a small molecule, a square is a peptide. So as I was mentioning, there's different ways of targeting the cancer. Most of these are directed at PSMA, like all these late stage ones. And then, but there are some that are other targets. So here's one, for example, that is, instead of PSMA, it's targeting a different molecule that is overexpressed on prostate cancer cells, so called castration-resistant peptide receptor, TRPR. So people are exploring some other targets, although PSMA is definitely the main one that is the focus. And the other point I'll raise in this figure here is the color. So you can see each color is a different radioactive molecule, different isotope, a different payload. And so while most of the stuff that's near the clinic is green, which is our lutetium-177, like in Pluvicto, you can see that there's a lot of action in the first in human side of things centered around that actinium-225, these alpha emitters. And Novartis even has basically an alpha emitting version of Pluvicto over here in phase 2. But you've also got people doing things with radioactive forms of copper and iodine and thorium and other things you've never heard of, samarium, rhenium, or I've never heard of. And also, this is the pipeline just for prostate cancer. If we zoom out, I mean, this is the full pipeline. So you can see Pluvicto is just the tip of the iceberg, and Lutathera for that matter. But companies are trying all sorts of things for all different sorts of targets and all sorts of different cancers, from breast to stomach to lung to kidney to blood cancers, you name it. Okay, so this is a hot area of drug development, and as people basically take radiation from this physics-based thing of trying to find out how best to shine the radioactive beams at your cancer to this biological approach of saying, what's the biological molecule that's expressed preferentially on these cancer cells, and how can we get the best radioactive payload directly to those cancers. So again, Pluvicto, that's the drug that started this. I think someone has said, this is not medical advice, but this is the closest I'll give you to medical advice. My apologies. I'll just note that the approval is limited to PSMA positive. You got to have PSMA, so you got to do the imaging modality first. Metastatic, castration-resistant, so you've taken an androgen receptor pathway inhibitor and it hasn't worked, and chemotherapy. So it's basically like the latest line possible. But there are late-stage trials now as they try to expand the indication, expand the number of patients who can benefit from this drug. So there's some late-stage trials looking still at people with castration-resistant, but now chemo-naive or hormone-sensitive. So again, kind of moving up the treatment paradigm, or not quite to non-metastatic, but this was a term I just learned, actually, oligometastatic. So I think it's defined as having 5 or fewer mets. So still metastatic, but not kind of widely spread throughout the body. So that's where the late stage trials are, as they try to expand the label indications. But there's so many trials with Pluvicto now, exploring all sorts of different things. So for my California audience here, I picked out some trials that I found, and you can find all these on clinicaltrials.gov. My apologies if I'm overstepping on giving anything approaching medical advice, but ask your doctor. But so they're trying different dosing schedules. That's a trial in LA. You've got currently, there's a definition of what it means to be PSMA positive, but there are people who kind of fall in this gray zone of they don't quite meet the threshold for full positivity, but it's not absent either when you do the imaging test. And so there's a trial looking at, could Pluvicto, given how targeted and strong it can be on those cancer cells, does it work in low PSMA expressing disease? And so that's in LA and San Francisco. There are combination trials combining Pluvicto with checkpoint inhibitors, immunotherapies, maybe cell cycle inhibitors, I think, as well. All different sorts of drugs happening. Those are some trials at UCSF. And then there's, I think currently, people get one course of therapy with this, but now they're seeing, for people who respond well and are living longer, maybe we should try giving it again and see if it makes them live even longer. So that's another trial with Pluvicto happening in LA. And before you accuse me of being a shill for Novartis, I'll just highlight a couple of other things happening in California. There's a trial with that actinium payload warhead that I was describing. Basically, this is trying to be like Pluvicto, but with that alpha emitting payloads. This is a trial, a drug from Fusion Pharmaceuticals, which was the focus of a recent multi-billion-dollar acquisition by AstraZeneca. That trial is open at UC Irvine and UCLA. And then that GRPR targeting drug that I mentioned as well from Clarity that uses a radioactive copper, that's happening up at Stanford for metastatic castration-resistant. So, lots of action happening as people try to build on the success of Pluvicto and find other ways to use it in other settings, and then also to maybe improve upon it. Before you accuse me of being like far too rosy about everything, I will say, not all the trials are kind of going fantastically. I mean, this is data from a trial that was recently presented at a molecular oncology meeting in Barcelona earlier this month. And I bring this up just to point out that, so here's a rival drug. It uses lutetium-177 like Pluvicto. It uses a different kind of targeting modality to target the PSMA. The developers of this were hoping, that it would be better than Pluvicto and really more tolerable. They were giving it lower doses and things like that. Ultimately, the side effects were kind of the same. And you're not, in clinical medicine, you're not really supposed to compare across trials because the drugs aren't tested head to head, and each trial has its own kind of quirks and idiosyncrasies, but everyone does it. It's kind of just like, we're not, with the usual caveat that we're not supposed to compare against across trials, we're going to do it anyways. I'll just highlight a couple numbers from this trial and just pull up the comparable numbers for Pluvicto. So this is the hazard ratio on the survival. So basically what kind of a survival advantage the drug gave, and a higher number is better. So Pluvicto was actually a little bit better. This is the percentage of responders. So patients who saw their tumors shrink, or all their metastatic lesions shrink by 30% after treatment. It was 38% in this trial, 51% with Pluvicto. Again, not apples to apples, and the placebo rates differ and stuff like that, although the hazard ratio captures that. But just to point out, there are going to be drugs through that earlier pipeline that I showed that, don't improve upon Pluvicto, or if nothing else, every drug is a little different. So in theory, if you fail Pluvicto, you could try this. But some drugs are not going to move the needle fantastically, and I would argue that this might be one. And the other thing to highlight is that I focused most of my talk here on these radiotherapeutics and this idea of using radiation to target PSMA. But it's just kind of one of many modalities that the industry is using and that drug developers are designing to target PSMA. So again, here's the jargon: therapeutic radionuclide. That's what I've been talking about. These radiopharmaceuticals paired with these imaging agents, and they're targeting PSMA. But equally exciting, and I just haven't, I wanted to focus my talk here, but what I would say is over here, these modalities, CAR T cells that people may have heard about, mostly have been used for blood cancers, but this is the idea where you take a patient's T cells, their immune cells, the cancer-fighting cells, and you engineer them with a special kind of receptor to target PSMA. And so now these engineered T cells, you put them back into the body and they will go around and try to find the T cells and attack the cancer. Or sorry, find the PSMA expressing cells and attack. So that's one area of development. And in a similar vein, you have what are called bispecific antibodies. So it's a two-armed antibody essentially. With one arm, it latches on to your target PSMA, so it catches the cancer cell. With the other arm, it latches onto a receptor found naturally on your body's circulating T cells, brings them close together, and then hopefully helps you mount an immune response. So it doesn't involve radiation at all, but it's just another way that drug developers are trying to find ways to help attack prostate cancers, and I think that's also a very interesting area of drug development to watch. And I would say it's been pretty exciting time for prostate cancer drug development. I probably don't have to tell you guys. You guys have a whole forum devoted, well, maybe not just to this, but among other topics. And if anything, things are getting better. I remember when I was first just getting into science journalism straight out of grad school, and the first cancer vaccine got approved, Provenge, Sipuleucel T, and there was so much excitement, cancer vaccine, and it was kind of a dud. I mean, it's still used a little bit, and I'm sure you guys can tell me why it's, better than maybe it is given credit for, but, it wasn't really that huge. And you had things like Xofigo here, which obviously helps deal with some of the bone mets, but is not really prolonging life. And then we moved forward into the late 2000s, and you're getting immunotherapies, you're getting PARP inhibitors, and Pluvicto, I think, sorry, this ends at 2022. It's not there've been approvals since then, but it's like culminating in the approval of Pluvicto, which it's not the be all and end all, but it's, I think, ushering a really new and exciting area of drug development for prostate cancer, and developing drugs that hopefully can help some of you guys, if or when you ever need any of these agents. So with that word of optimism, I will take any questions, including I will look in the chat and see what I missed. But, this is a picture here of, this is actually a picture of how Pluvicto is transported, if anyone's curious. So these little green vials, they call them pigs. I don't know why, but they're like lead-lined little capsules that they put the Pluvicto in, so that the radiation is contained, and everything has to be very carefully transported. But anyways, and I'll plug my Noble article again, and yeah, I will gladly take questions, either from the chat or just talk to me. But let me see. Can I start with this question from Ira?
Please, go right ahead.
Do I know much about terbium-161? Oof. I don't, but it sounds cool. Is it an imaging agent, or is it a beta emitter, an alpha emitter?
It's beta, like lutetium.
Okay.
There's a trial in Australia. I read about it maybe a year and a half ago, and it was in phase 1. But what happens is, as I understand, it has something called auger electronics, which goes a shorter distance. And because of that, it could get the micro metastatic disease that lutetium doesn't get.
Okay.
So, but I just read something a year and a half ago, and since you're here, I thought you might know something about it.
I mean, I'm sorry, I don't. I mean, one of the things is the field has exploded so much, so it's hard to keep track of everything, especially everything in kind of first in human or early stage development, and you have to kind of assume that a lot of those are going to fail. That's just the nature of development. So in general, I'd put more stock in things that have entered a randomized phase 2 or phase 3 trial to get that. But anything that shows proof of principle in a phase 1 is also can be really exciting. So I'll definitely look into that. Thanks for flagging it.
Neil, I thank you very much for that talk. What a wonderful set of slides that is. That's probably the most comprehensive and easy to understand slide set I've seen in a long time. We really appreciate you making this effort for us tonight. My brother-in-law was in the Barcelona meeting, and he didn't mention anything to me about anything new in prostate cancer. He's an expert in something else, but at any rate, thank you very much.
Maybe because that talk was underwhelming. So yeah, it was a bit of a bummer. But there are a lot of interesting things at ESMO, but just not in the radiopharmaceuticals.
Yeah, we had a big question at our last session, our support meeting about low PSA expression and theranostics, and what do you do? I know you mentioned it, but could you elaborate on it just a bit? It seems like we have several fellows now that are waiting for their PSA to go up so they can at least consider theranostics.
So we're talking PSA or PSMA? I mean, it's an unfortunate.
The PSMA expression.
Right. Yeah. So there's an unfortunate nomenclature that the two sound so alike. You know, PSA being this like key diagnostic thing, but then PSMA being the target. So sorry, the question is people waiting for it to go up so they can get the therapy?
Well, they're being told that at the low levels it just isn't effective.
Yeah. Well, that's being tested, you know, in a very exploratory academic trial, I suppose. As you know, the way that drug development works, they're going to have very rigid inclusion criteria, and they, you know, design the trial so that they hopefully, you know, learn something, but also get a positive result. So of course the trials were limited to the patients who they thought would benefit most, who had to have PSMA expression above a certain level. Does it work when you have some but not a lot of PSMA? I mean, that's a fascinating open question, and one could imagine, just this is me speculating, that the more potent the drug is, the more that might be likely to work. You know, if it's a real kind of actinium alpha emitting type drug, that is, as long as it doesn't cause too many side effects when it's in circulation in the body, as it's kind of running around the blood trying to find its target, because there's going to be fewer targets, so there's going to be more unbound drug, and thus perhaps more just sort of scattered radiation through the body. But in principle, you know, if it really can find those hidden nodules of cancer, that could make a difference. That actually, and whether it can find the micromets, I mean, that also has something to do with the nature of the targeting molecule, because small molecules and antibodies and these different kinds, the size of the molecule and its own nature will affect how well it can penetrate into like the tumor microenvironment and the whole kind of immune exclusionary environment that forms around a cancer. And so that can matter too. I mean, all the design elements. But I think we just kind of have to wait and see, as typical drug development, you start late line when all else has failed, and you then move it further up and try to find who are all the different patient groups for whom it could benefit. Including, I think someone here, Russ Meyer, asks, you know, do I think this could be used for non-advanced, non-metastatic cancer? I mean, in principle, yes. There's no reason it shouldn't work. You don't need metastatic disease. You put in the bloodstream and all your cancer's in the prostate gland. I guess the argument probably becomes one of cost, logistics, need at that point, because you guys will undoubtedly push back when I say this, but you know, we have effective treatments for localized disease. Obviously, everything has its problem, from localized radiation to surgery. And Pluvicto is just a more expensive drug, and so you come into health economic arguments. I mean, biologically, I don't see why not, but just the nature of healthcare and as it is, it seems like it's a kind of a less important use case, if you will, just given what else is available and the clinical need in metastatic disease, where nothing like Pluvicto has kind of been that effective at finding all the scattered shot tumors throughout the body.
Very good. Thank you very much for a really comprehensive discussion. Appreciate it.
Yeah, no, happy to do it. Yeah, I'm happy to take any questions offline if anybody wants to follow up as well.
Outstanding. Well, Elie, it's been outstanding. As you know, this is going to go on YouTube, and it's going to be pretty much all over the world. And we're going to make reference to it in our groups as an educational tool. For those of you not familiar with the prostate forum, you can learn more about it at our website, www.prostateforum.org. Feel free to sign up for our meeting announcements. In the Join Us section of our website, there's 10 years worth of videos, very much like this one, on our website. Go to presentations, check out the pull down menu, spend some time with it, and you'll find it's a wealth of well-organized resources. Also, we run entirely off of donations. We're all volunteers here. Feel free to either contribute via credit card, via PayPal, or your own PayPal account, or you can send us a check made out to Prostate Forum at 1519 East Chapman Avenue, Box 380 in Fullerton, California. 92831 is our zip. We look forward to having you back, Elie, and we thank you for your time and for staying up late with us. And Prostate Forum has 2 support group meetings every month, including December, on the 2nd and 4th Tuesday of every month at 5 p.m. Pacific time. We look forward to seeing you at the support group meetings, and we look forward to seeing you at future presentations. And we hope you take advantage of our website for more educational materials. Unless somebody else has something else, I'm going to say good night.
All right. Have a good evening.
Good night, everybody. Thank you again.
Thank you again.
Wonderful presentation.